everyone. We are here at the AUA meeting 2025 for GU Oncology now. My name is Murilo De Luz. I'm a urologic oncologist at Mount Sinai in New York. And I'm here with superstars in the field for advanced prostate cancer. We're going to have a very nice discussion and we'll let them introduce themselves.
Sure, happy to start. My name is Gregory McMahon. I'm a urologist based out of Philadelphia with MidLantic Urology, mostly focused on GU oncology, disease states, and also run our advanced prostate cancer center.
Dan
Oberlin. I'm a urologic oncologist out of Berkeley, California. I focus on mainly minimally invasive cancer control as well as longitudinal care of prostate cancer.
Hi, Gordon Brown. Nice to be here. I'm a urologic oncologist in southern New Jersey and focusing primarily on prostate and bladder cancer. Glad to be here.
Great. Thank you, guys. And so we're going to start where we usually see those patients with the diagnostic of locally advanced or oligometastatic prostate cancer. We know there's a lot of developments in diagnosis this last few years actually, and particularly I think one thing that always comes in mind is PSMA PETs. I mean, this is new. We are doing as like a routine in many places, although not everyone has access to that. So I'll start with Gordon actually with a very specific scenario. So first thing, is PSMA like routine for you nowadays? There's still someone using like conventional imaging, CT scans, bone scans, and would you do conventional image and then PSMA, or are you going straight to PSMA? So that would be my first question, and then I'll go to you guys for some of the diagnostic questions that I have as well.
Yeah, so for the on-label patient, that grade group 3 or higher patient at the time of diagnosis, PSMA is pretty much routine for me, for staging purposes. The only time that we would use a conventional CT bone scan would be in the setting where, for whatever reason, insurance company either requires that prior to PSMA PET, which unfortunately still does happen, or there wasn't access to it. In our marketplace, we have reliable access to that technology. So for those patients who are unfavorable intermediate risk and higher, routinely we're getting PSMA PETs on those.
Yeah. Okay. You mentioned something. Just come back one thing about the insurances for the primary diagnosis. So for patients that are biochemical recurrence, we're not talking about that at this moment, but some insurance would have as a limit, like 0.2, 0.3, or 0.5. Are you facing this like when you were in PSMA as well?
Yes, but to a much lesser degree in the BCR setting. So in the BCR setting, they seem to be much more willing to certify the use of PSMA PET. It's the upfront patient that we're having to either step at it or go through traditional CT bone and then get to PSMA based on insurance kind of recommendations or the protocols, which seems ironic because now you're kind of doubling imaging and you're actually doubling the cost of care for that patient. Right. I suspect in the near future they'll catch up with the guidelines and hopefully we'll be able to avoid that interval step.
That's great. Then with this new imaging, of course, nothing's like just flowers. And we are seeing, and I have in my practice seen quite a few patients that actually I'm not 100% sure that this is metastatic disease.
Yeah.
So you're not expecting that. What we call like the pre-test probability was so low, intermediate risk, low PSA. You're really not expecting some metastasis. And then you see one single bone spot, one single lymph node outside of the pelvis. How are you dealing with those patients? Are you going straight forward and treating them as metastatic disease? Are you giving the benefit of the doubt, or you trying to do something else, biopsy or giving some other tests?
Yeah, it's a great question. I mean, they're challenging patients. I mean, these patients, because the test isn't perfect, so there are patients that have lower SUV enhancement on these scans, which are going to show up. And so I usually try to do a very personalized approach for these patients, and I talk to them about where this enhancement exists and what their options are. Some patients will want to treat it as a metastatic node and may potentially go straight towards radiation and androgen deprivation therapy. Other patients may consider a biopsy. So it's a very personalized discussion for me.
That's good. Yeah, I fully agree. Gregory, that's maybe a tough question for us as urologists, but any other tests are you doing for this patient that you're considering like metastatic disease initially? We do PSMA, we do MRI. Genetic testing, any space in this scenario? Are you testing the tumor or genomic classifier, some Decipher oncotype tests? Are you doing any routine all of those, or selecting for a specific case?
Yeah, so there's certainly a lot of genomic tests that you can use, and I think whatever the physician's comfortable with that they reliably use that may help with treatment intensification or de-intensification is smart. But in terms of genetic testing, that's we had a nice session about that earlier today in the AUA. Really, patients that are high risk, very high risk, or metastatic should be getting upfront genetic testing, and then somatic testing that becomes indicated in the metastatic disease space. I think that's important to get one, because it may open up future treatment options for that patient, especially as we're seeing those agents being pushed forward in disease states. I think right now there's a couple of trials that have PARPs with metastatic hormone-sensitive disease. But then also for their next of kin, should they start being screened earlier for a plethora of disease states as well, cancers as well.
Just going back real quick to the conversation around the equivocal PSMA scan. So looking at both Condor and Osprey, right? Trying to get tissue as standard of truth, I think, is an important aspect that we should at least mention there, right? So I think if tissue's able to be obtained safely and we're considering localized therapy, then I think that I would try to biopsy that patient to establish, and reconcile that PSMA result, and then treat based on that biopsy result. Meaning that, for example, we have an external iliac node, equivocal SUV, Gregory 3 disease, PSA of 8, whatever the case may be, and it's a biopsy negative node. I feel a lot more comfortable taking that patient to radical prostatectomy, for example, in the age appropriate setting than I would be committing them to ADT plus hormone therapy. The question to be, if it's a negative biopsy, or if it's inconclusive, or you can't sample it, then how do you manage that? And I think that becomes a little bit of a nuanced conversation with the patient, right? Trying to understand risk benefit, because if it truly is metastatic, then maybe they're not being benefited by localized therapy in the majority of cases. However, a subset will see prolonged benefit. Nonetheless, I think that patient deserves that conversation to be held kind of in a very thoughtful fashion,